ways we can take the temperature. The one that you'll probably see the most often in the hospital is one, we do the oral temperature very often. The book talks about how it's the most convenient, which is probably true, but it says it's the most accurate, which is not true. Rectal is your most accurate representation of core temperature, but the reason why we don't do rectal all the time, why do y'all think?
It's invasive.
It's invasive, cross-contamination, infection, also possibly puncturing the rectum, and that's something we don't want to do. So usually in the hospital we're going to be doing oral. So you have the ones that are connected to the Dynamat like this. And one thing I want to note when you are doing your oral temperatures, you still may see some of the machines have a red one like this, or your portable thermometer so this would be on the wall, this is your charger, they would have a red hole for your red thermometer, that's rectal. So we use the red thermometers for rectal, the blue thermometers for oral and axillary. So very, very simple. When you have it on the Dynamat, you take your probe and you have probe covers. So you would click down. Always make sure that you feel and hear the clicks. That means your probe cover is on your thermometer. And then where do we put this? Under the tongue, right?
Yes.
Okay. Then we have to take the probe off, so you just click it, and then you throw it in the garbage can, okay? Same thing, same concept with your portable ones. Your portable one, the good thing, they have the axillary to where it's pointing to underneath the arm, so you just hit the button when you want to take an axillary. Some thermometers, you'll see it'll actually be written out. So you can do it that way, and then of course you just guard this. And like I said, rectal is the red. What do we need to make sure when we do a rectal temperature? What position we want the patient in?
Their left side.
Left side, leg up, and then what do we do to the probe?
Lubricate.
Lubricate it. And we insert it about an inch in the rectum, and we wait for the thermometer to read, and then we take it out. And like I said, that's going to be your most accurate, but we don't always do it. The other type of thermometer you may see, this is your tympanic membrane thermometer. This actually takes the temperature, it's reading off the tympanic membrane. The tympanic membrane is perfused by the internal carotid, which also perfuses the hypothalamus of the brain. And the hypothalamus does what?
Temperature regulation.
Temperature regulation. So it's a good, accurate representation of our core temperature. Same process, so you're going to use a probe. So you just click down, you get your probe on. The one thing you have to make sure with these is that it's inserted into the canal correctly, because if it's too far out, then you won't get a good reading. And so you take your patient's ear, and so the normal anatomy of an adult canal is slightly curved, so we want to straighten it out. So 3 and up, we straighten out the canal by up and back, same way when we're looking at it. And then we insert this into the ear, you press down, and then it should give you a reading, and then you can change it to Celsius or Fahrenheit. Same concept, we want to take the probe off and discard it. Okay? Questions about this one? Okay. I don't have a temporal artery thermometer to show you, but I'll just kind of explain it using this one. So usually a temporal artery thermometer has more of a blunt circular tip, and what we're trying to measure is the heat put off by the temporal artery. Temporal artery runs right in front of your ear all the way down to the carotid, or the carotid up into the temporal artery. So we would put our temporal artery thermometer on the center of our forehead, and you go all the way to the side by the temporal artery. Most temporal artery thermometers, the company will tell you to also, when you get to right here, put it behind the ear as well. And you're holding this down the whole time. One of the reasons being is that the forehead has a lot of sweat sometimes, less than what it is behind the ear. So they want you to get that good, solid reading behind the ear as well. So that's your temporal artery thermometer. You see that one done a lot of times in like PACU when the patient can't open their mouth and get their thermometer temperature read. They'll do that in PACU a lot of times, or like clinics. But most times on the floor, it'll be this one.
What do you call the thermometers they're using in hospitals right now that they just scan it? It's kind of shaped like a gun and they just pull
I
it?
know what you're talking about. Honestly, I'm not sure of the name. That's a good question. That one is probably the newest, I would have to say. technology, and I'm not sure, that's a good question, we'll have to look that up.
It probably works like an infrared,
That's what I
Mhm.
thought too.
like when there's food thermometers now that you can do that with, when you
Yeah,
shoot it at the
I just
turkey.
Googled it, they just say infrared.
Oh,
for
okay.
that.
Yeah.
Okay.
Mhm.
I don't know if it has like a body name, like tympanic or
know.
oral, but
Because,
it's touchless and that's why
Right.
it's really good during COVID.
yeah, absolutely, good question. Okay, so that's kind of our temperatures. What do we wanna make sure though, when we're doing an oral temperature, we're gonna ask the patient that they
They
just.
hadn't ate anything that's cold or hot.
Yeah, because we don't wanna take it right after, right? Because we'll have a false reading, a low reading. So we'll tell them we'll wait about 5 to 10 minutes and we'll come back and take it. Another thing is we wanna make sure they didn't just do what?
Like walk around or mobilize?
Yeah, we kind of want them kind of resting, but also we don't make sure they didn't just smoke because that can cause vasoconstriction and we can get a false reading that way as well. Okay, so let's talk about respiratory rate. Does somebody want to tell me how we take respiratory rate?
It's one inspiration and one expiration is
Uh-huh.
one
Yes.
respiration rate.
Yes, and just like the book says, and this is what I do in practice as well, when I'm taking my radial pulse on my patient after I get my number, that's when I watch the patient breathe, and you're gonna watch the chest rise and fall. Why is that?
Because if somebody know you doing it, it'll throw off their breath, yeah.
They're gonna be, right, they're gonna be watching themselves and thinking about how they're breathing. So after you get the pulse, then we get the respiratory rate and you're watching the clock, and you can make it more awkward than it needs to be. You can be talking to the patient and that's when you have your watch on or looking at the clock and getting it that way. So we got our respiratory rate, and what about our pulse? Where do we find our pulse at, or count our heart rate? Our radial artery, okay? The way I always think about it, and this is just my little thought when I was a nursing student, you have your ulnar artery, and you have your radial. Ulna is a smaller word, so ulna is by the pinky side, and radial, more letters, so that's the thumb. So if you try to feel for it, 3 fingers or 2 fingers, and you lightly press, I always make sure that the patient has extended their wrist because it brings that artery up to surface, and you just feel for it. Y'all all try to feel for y'all radial pulse. Y'all feel it? Good. So you have your radial pulse, and then you have your brachial pulse. Your brachial pulse is kind of medial to your flexor surface, your AC of your arm. So your brachial pulse is going to be like right here. And again, you want your patient extending their arm to bring that artery up to surface. Everyone try to feel theirs? Feel it? Sometimes you kind of have to like go press a little bit if it's not at the surface for you. Extend your arm. You felt yours doing it? Feel it? I see the eyes. I know the eyes. Feel right here. You feel that? Good. Everyone felt it?
Less strong than the other one, like is it?
I wouldn't say it's less strong. I find people it's easier for them to find the radial, because there's less tissue right there. But usually they should coincide, the number. Jamie, you felt yours? Felt it? Okay. So that is something, that's gonna come into handy, and play whenever we're about to talk about blood pressure, okay? So everyone felt their pulse, you count it, how often do we count our pulse? How fast, how long do we
60
count our pulse?
seconds, unless it's normal in 30 seconds, and then you can multiply it.
Multiply it by 2, but if you're feeling it and it's irregular,
A
it
full
would be
minute.
The full
a
60
full
seconds.
minute, yes. Same thing for respiratory rate. You can count for 30 seconds, but if the patient's breathing, see regular, right? Then we have to count for a full minute. Good, okay. Now let's talk about blood pressure, okay? So, to talk about blood pressure, we would be doing an injustice if we didn't talk about Korsakoff sounds. Can someone tell me what a Korsakoff sound is? So those are the sounds that we're listening to when we take a blood pressure. That's the blood flowing through those arteries, the turbulence of that blood, the sound we hear, okay? So before we get started, I'd like to play this video for you guys to get kind of an understanding of what a Korsakoff sound actually is. So, little background, there are 5 Korsakoff sounds that we are listening for, and as the sound changes, the number changes to the sound, okay? Everyone see it okay? So it's going to show you which Korsakoff sound is when you're hearing it. The first one is the first sound you hear, okay? And that's your systolic number. See how it slightly changed there? Decrease. Your 5th sound is the silence. So after that last sound, your diastolic pressure is going to be the silence after that last sound. Okay, the absence of sound. So that kind of brings to light what exactly a Korsakoff sound is. And so it's important for us to know that because, let's see, like it said, that first sound is going to be your systolic pressure. So a heartbeat consists of a systolic pressure and a diastolic pressure, right? Systole is the big contraction of the heart, the maximum pressure the heart exerts to push out that blood. The diastolic, or the absence of sound, is going to be your heart relaxing. The least amount of pressure the heart feels in its relaxing stage when it's reperfusing the blood, okay? And so there's something that is termed the oscillatory gap, okay? And this is probably the thing that students have the most trouble understanding because it's a little confusing. I'll definitely admit that. But let me try to see if I can help you guys. So, the oscillatory gap occurs between Korsakoff 1 and 2, okay? And just like these 2 words say, it's oscillatory, so it's something we're listening to, and it's a gap, so it's silence, it's an absence of sound, okay? So, not every patient has an oscillatory gap, only a select few, okay? And usually an oscillatory gap occurs with patients that have high blood pressure, hypertension. And basically what happens is that people with hypertension, and this is not everyone with hypertension, only some, their aorta they have linked it to their aorta is really stiff. So it doesn't allow that elasticity of the blood to make the sound, the oscillatory sound. So they have this absence of sound they've noted between the first and second quarter cough sounds. To where, if I would say take my blood pressure cuff and I would just be pumping up that cuff to 150, okay? And I pumped it up to 150 and I was in between that oscillatory gap, what would be the first sound I would hear taking my blood pressure? That second quarter cough sound. And let's say that second quarter cough sound was at 130. I would think my systolic pressure was 130 when it really could be 170. But I missed that first quarter cough sound. Does that make sense? So the way we get around that is it's an oscillatory gap. It's not a palpatory gap, okay? So I can still feel when that gap is occurring, but I wouldn't be able to hear it, okay? So what you do is you find your brachial artery, your brachial pulse, or you can do radial, whichever, and you're gonna take your blood pressure cuff and you're going to inflate that cuff while you're feeling, and when you stop feeling, you take that number and you add 20 to 30 millimeters of mercury, and that is what you're gonna pump up your blood pressure cuff to listen for your blood pressure. Let me try on somebody for y'all to get the picture. Kiana, can you come up here? And I'm gonna get your blood pressure and show them. Let me try to bring this together for you guys, because I know it's a lot, you just gotta let it sink in for a second, okay? So what are some things we need to make sure when we're taking a blood pressure? That the patient's feet are on the floor, their legs aren't crossed. What'd you say, Candace?
Her legs aren't crossed.
Her legs aren't crossed, correct, Christy? And then we wanna make sure her arm is at the level of her heart, okay? So we don't want her doing it standing, or we don't want her like this. We want it at the level of the heart. Okay, so first I'm gonna palpate her brachial pulse. So I feel it right here, or like I said, you could do radial. So we palpate the brachial pulse, and then we wanna put our cuff about 2.5 centimeters above that. Now just FYI, some of y'all cuffs may have a left or a right line, meaning that if you're taking the blood pressure on the right side, you wanna put the right line or arrow above where you palpated that artery, vice versa, left, okay? So you position the blood pressure cuff, and then, where's your, oh, you know what? Do you have a blood pressure cuff that we could borrow?
Right there on my desk.
This is fancy. This is the one I brought from work, and it has one of these, and y'all will not be having probably one of those in the hospital, so I want to try to show y'all's. Okay. So again, I palpate it right there. You see she has the right arm arrow, so that goes right above where I palpated it. This is your sphygmomanometer right here. That's going to show you the millimeters of mercury of the pressure. Always remember, righty-tighty. That's how you close off your bladder. That's going to be inflated right here. So I found brachial artery. I palpated it. So I'm going to inflate my cuff, and whenever I stop feeling that artery, that pulse, so I stopped feeling it at 130. So now what I'm gonna do, guys?
Add 20 to 30 millimeters.
Add 20 to 30 to when I stopped feeling, when I stopped palpating that pulse, and that is when I'm gonna inflate it to listen for my blood pressure, okay?